more of a discussion on the pathophysiology of the valves. But in this semester, we're just going to talk about the normal 4 valves that are located in your heart. Okay? You have to understand the valvular anatomy. That's what I'm going to ask you on the test. Function of the valves. Okay? Different types of valvular diseases. We'll talk about that next semester. The progression of valvular diseases, that's all talked about next. And then all these other ones, which is eventually you're going to have to know, which is next semester. I'm just sort of showing you that we are going to cover it, which is aortic stenosis, IHSS, aortic insufficiency. All that will be covered next semester. Let's just do anatomy first to make sure that you guys get that down so you're ready for your test. Okay? There's only 4 cardiac valves normally. Okay? There's the going from cephalad to caudad, which means from your brain to your legs in that direction. Okay? It's called PAM-T. Okay? Pulmonic valve is the most superior. Aortic valve, mitral, and tricuspid. Okay? The one that's most difficult, well, I'll just get into it. Let me just go on to it and I'll explain the other part. The anterior to posterior, which means chest, front to back, okay, is pat me. The way you remember it is pat your chest. Okay, pat me. Okay? So it's pulmonic, front, aortic, okay, tricuspid, and mitral. Now, why do I make you memorize it? Well, because clinically it does matter. Okay? Very soon, in about 6 or 7 months from now, you're going to be working in cardiac surgery cases, or years from now. You'll be doing cardiac cases. And you'll be having somebody place a TEE, including some of you who might be able to place it if you're interested in doing that. And then we'll get you to look at it and actually read it. Okay? So you have to know the anatomy. The valve that's most difficult to visualize under TEE is going to be the most superior and the most anterior valve, okay, which is going to be the pulmonic valve. So the pulmonic valve is the most difficult to visualize. Okay? The reason it's difficult to visualize superiorly is because that's where the trachea and the bronchioles are at. Okay? So it gets in the way, so when the TE shoots the ultrasound through it, the air distortion causes you to have a very difficult time visualizing it. Okay? The easiest valve to see, on the other hand, is the one that's posterior the most and inferior partly, which is the mitral valve. The mitral valve is very, very easy to see, as well as the tricuspid valve, but by far the easier one to see is the mitral valve. Okay? If you look at this anatomical structure, I might give you this picture, okay, and then I'll tell you label it. Okay, I'll ask you which one is the aortic valve, and you got to always look at it from the standpoint of how's the heart sitting. Okay, if it says posterior, which is the most posterior valve? Mitral valve. Okay, the most anterior valve is the pulmonic valve, aortic valve, tricuspid valve, and mitral valve. Okay, so if I give you this picture where I flip it around and I say anterior, posterior, you got to figure it out. Okay, because they may actually ask that as part of an anatomy lesson. The tricuspid valve is the first valve you reach when you come in from the right atrium. This valve is a fairly large valve area. Okay, depending on which book you read, one book will state it as 9 to 11 centimeters squared. The tricuspid valve is very large in comparison to the mitral valve. It's actually a little bit larger. It's composed of 3 leaflets. That's why it's called a tri, like a tricycle. Tricuspid means it's 3 cusps. Okay, it's got an anterior, posterior, and septal wall. The 3 papillary muscles are less risk for papillary muscle to get ischemic because the right ventricle is perfused through the whole cardiac cycle. Okay, so the papillary muscles tend never to disrupt in the right ventricle. You don't usually see a tricuspid blowout or something like that. The other thing, the papillary muscles are not under a lot of high pressure unless the person has pulmonary hypertension. And the chance of you actually getting a papillary blowout is very, very infrequent from a tricuspid valve problem. Okay? The right ventricle is perfused throughout the cardiac cycle, which is a very good thing. And the attachment points between the papillary muscles and the valves is not direct. It's by a connection used by what's called a chorda tendineae. Okay? The way you want to think about it is think about parachute. Okay? When you look at a parachute, the way it's structured, the initial bands that are coming up are made out of nylon that are heavy duty, and then when it comes out is parachute cords. which are made out of very thin silk, well, not silk, but they're made out of nylon material now. Used to be made out of silk, okay? High quality stuff, okay? Now, what's interesting about this is most likely whoever started inventing this must have had some kind of anatomical discussion about this. And actually, one of the persons that first described a parachute was Michelangelo, okay? And what did Michelangelo also work on? Anatomy. So he was playing with this inside, opening up the heart. And he's got pictures of the heart that looks very similar to his parachute, okay? So he sort of he understood the mechanics. He was also an engineer. So he understood the mechanics of how the valves most likely functioned, okay? The pressure inside the right ventricle is low, okay? So usually it's not as important for for maintaining the valve completely tight. It's important during the active isovolumetric phase of the right ventricle for the papillary muscle to contract to make sure the tricuspid valve stays in a tight condition. This is a nice TEE picture, okay, what it looks like. This is a 3D TEE showing you how the actual tricuspid valve opens during different portions of the cycle. If you have time, it's not something you have to do right now, but when you do have time later on, if you need clinical, if you want to learn how to use TEE, there's a great website that has it. I've got a linked thing to your class, so you can review that there as well. And it actually has pictures of what it looks like in different views of the TEE. What I want you to do is make sure that you understand the EKG in comparison to your A, C, and V wave, okay? Where the QRS is indicating where the C wave's at. The actual A wave is during the diastolic time. The tricuspid valve now is open. So this is the right atrial pressures. This is the CVP, in other words. You'll see that the tricuspid valve will stay nice and open for you, and all the way through atrial kick. Okay, and that point, at the C point, that's when the actual tricuspid valve completely closes, and as well as your pulmonic valve is closed until it opens a little later on. Okay, you can see here that the right atrial volumes are significantly the lowest at what point? At the atrial kick. Okay, so let me ask you that in a test question. I'm not sure they ever will, but you know, what's the lowest amount of volume inside your right atrium? And the answer is at the A wave. But one of the things that's tricky about the question is, is there a pressure, high pressure at the A wave? And the answer is yes. It's higher than the mean, okay, because that's a part of the atrial kick. This is one that's not consistent with volume. So if you use an A wave as an indicator of volume, that's not really good, because look what it's doing. Volume is going opposite to the direction of the A wave. Okay? And this is important when we talk about PA catheter discussions next semester about how we actually measure preload. Preload is right here. That's the point of maximal volume inside the right ventricle, right before the C wave. The pulmonic valve has a small valvular area of 2.5 to 3.8 centimeters squared. Okay? Most of your pulmonic valves are the size of your thumb. If you take your thumb and look at it, that's a 2.5 centimeters area. That's your surface area of your pulmonic and aortic valve as well. The pulmonic valve is a semilunar valve most of the time. Okay, so it's not a tricuspid valve. Sorry, it's a tricuspid semilunar valve. Okay, it's a low pressure system. Okay, so it has less turbulence, so it's less likely to get damaged. So very infrequently do we actually have to worry about the pulmonic valve being stenotic or insufficient most of the time. Okay. Remember one thing, 100% of the cardiac output goes to the pulmonary circulation. What do they mean by semilunar valves? They have no chordae tendineae connected to it. Okay, there's no papillary muscle connecting to it. What they look like is they look like parts of the moon, lunar, like half a moon. Okay, and they open up and they cup. They're like little cups inside and there's actually three cups inside your pulmonic valve. Okay, there's also that same thing in the aortic valve. Okay, so the aortic valve and pulmonic valve had the same kind of setup. Okay. What you're seeing here, this is the right ventricular pressure waveform. So the intraventricular pressure that's generated here occurs the A wave, C wave, and B wave. That's your CVP. But as soon as the ventricle is overlaid on this red line will overlay over this, okay, which is a ventricular pressure. Make sure you note here that there's no dicrotic notch in the ventricular pressure waveform. Okay, there is no dicrotic notch. Okay? That would indicate that's in the pulmonary artery at that point, because that would indicate there's a valve separation between the ventricle. Okay? You can see the right intraventricular volume is basically maintained after the atrial kick, all the way through the isovolumetric contraction phase. And then right here, this is the point where the actual intraventricular volume begins to fall off. Okay? Now, the reason that the right ventricle can continue to be perfused is that if you look at the pressure height, okay, the pressure height on this side would be maximally around 20 to 25. So that's be the highest in your systolic pressure in the pulmonic circulation. And the coronary perfusion pressure usually operates on a diastolic pressure of around 100 about 70. So you have still a significant gradient, so you can maintain perfusion through the whole cardiac cycle for the right ventricle. The mitral valve is the next valve you'll encounter. The mitral valve separates the left atrium from the left ventricle. The mitral valve area is smaller than the tricuspid valve, and its area comprises around 3.5 to 6.5 centimeters squared. It's a bicuspid valve. Okay? The reason it's called the mitral valve is because of the mitre that the Catholic priests wear. Okay? If you look at a Catholic priest, they've got this two mitres, one in front, one in the back. And what's really cool about it is if you begin to watch carefully, you'll see that there's actually different sizes. There's one that's actually bigger in the front, and the one behind it is smaller. And that's what you actually have as well in this. And that's how you remember it. Okay? The anterior leaflet, which is like the anterior one to the forehead, is a large one on the priest. The one that's behind is smaller, just like it is in the heart. Okay? Because it indicates the heart of God, something like that. Okay? So most likely they were looking at the mitral valve and they said, well, copy that. Okay? So you had the anterior leaflet, which is much larger, and you had the posterior leaflet that's very small. Okay? When it becomes important for this discussion later on, and it will become important, we'll talk about the differences between somebody which has mitral valve prolapse and mitral valve regurg. It's two different diseases. It has to do with the anatomy of the valve. Okay? Because the posterior leaflet is so small, it's almost like a fixed valve. It doesn't really move. Most of the leaflet that's actually moving is the anterior leaflet. Okay? The posterior leaflet is sort of holding steady. Okay? If you have somebody with mitral valve prolapse, the way they become symptomatic is that the valve in dehydrated states slips down below this other valve, and then the person shoots up and gets mitral regurg during dehydrated states. If you give them volume, then the valve seats properly, and no longer do you get regurg. Okay? So somebody with mitral valve prolapse is sensitive to dehydration. Okay? And they do fine as long as you volume load them. On the other hand, if you have somebody with mitral regurg, the valve is actually now far apart, and when you give more volume to them, it gets even bigger, and regurgitation gets worse. So mitral valve regurg is a completely separate disease process, and it acts completely differently. One is volume sensitive, and the other one is not. Okay? The two papillary muscles are owned because it's only a mitral valve. The anterior papillary muscle is much more sensitive to ischemia than the posterior one. Because what did I tell you about the posterior leaflet? It doesn't move as much. Okay? So the anterior papillary muscle is going to do most of the work. So where do you see most blowouts occur from ischemia? In the anterior papillary muscle. Okay? Now, the problem with this is that the anterior papillary muscle becomes ischemic very easily if you get LAD disease or left main. So people that have left main disease or left anterior descending disease, and they get lack of perfusion, the deepest muscle, which is the anterior papillary muscle, loses its function, And once it does that, the mitral valve is not able to stay closed during isovolumetric contraction. The degree of ischemia will dictate how fast that valve will open. The more severe the ischemia, the valve becomes almost incompetent as soon as the ventricle begins to contract. Okay, during isovolumetric contraction, you get significant MR. Okay. The chorda tendineae also attach to the papillary muscles, just like the tricuspid valve. It's a very nice tendinous structure. Unfortunately, because it is a tendinous structure, it also can have attachment points for bacteria. So bacterial endocarditis, it can attack the chorda tendineae, ripping them up. The actual bacteria will eat through it, and then you'll have leaflet fluttering back, and you can actually see that under TEE. Basically, the mitral valve's function is to separate the left atrium from the left ventricle, especially during isovolumetric contraction. Okay? When you lose competence for that, you develop regurgitation. The important factor of this is that we monitor the left atrial pressures using PA occlusion pressure. The PA occlusion pressure is basically measuring the degree of preload to the left ventricle, which occurs right at the CVP. Okay? Because the compliance is different from the left and right ventricle, it means there's less compliance in the left ventricle in comparison to the right. You always expect usually that the PA occlusion pressure should be higher than your CVP, even though the volumes are the same. Okay, it's just a difference in the compliance curve. Again, when is the lowest point of volume in the left atrium? It's at the atrial kick as well. Okay? The most volume inside the left ventricle is actually at the V wave, okay, because that is actually indicating adequate refilling of the left atrium. So the V wave indicates the highest volume in the left atrium. Okay? The aortic valve is the last one we'll discuss, and then we're pretty much done for today. The aortic valve it separates the left ventricle from the aorta. The aortic valve area is about 2.6 to 3.8 centimeters squared. It's a semilunar tricuspid valve under normal conditions. This is what we talk about as a semilunar valve. Okay? Now, what makes the aorta very different than the pulmonic side is that perfusion occurs through this area. Coronary perfusion is originating from two cusps. So you have the right coronary artery coming off one, and then the other one is, right above it, is the left main. And this one is called NCC. What do you think that's called NCC for? Non-coronary cusp. Okay? This one will be called LCC, left coronary cusp, and that would be RCC, right coronary cusp. Okay? The perfusion is vital that you understand the anatomy that is occurring at the aorta, but it's right at the aortic root here. Okay? And when we talk about cardiopulmonary bypass, this will become very important later on. The coronary arteries are always attached at this point. If you don't, then basically you're not going to perfuse. If you've got attachments in the pulmonic circulation, that would not be good. Sometimes you get that, but usually most people don't survive that in the neonate because that would indicate to you low perfusion with deoxygenated blood, which would not be good for the heart. Under normal conditions, you see the normal aortic valve. This semilunar valve opens up very nicely. Okay, you can see how it opens up here in this picture. Okay, if you want to see a great picture, it's one of the books that we use for the DNAP. See if I can link that for you. We'll actually show the actual heart valves opening and closing. What they've done is they emptied out the heart of any blood, and they just use liquid, and that way they can actually see the valve actually functioning in this animal. And it's being perfused still in the coronaries with normal blood. If you look at what happens with the valve diseases is when you develop stenosis, it inches in from the outside inwards. So it develops like this, and eventually you get a very small area, and that's what we call aortic stenosis. Okay? Aortic regurg, we'll talk about next semester as well, is when you have the incompetence of the valve and the valve doesn't completely close. Okay? So this would be a certain degree of aortic insufficiency because the valve is not completely closed. Okay? Again, it's just your waveforms that I expect you to know. You're supposed to know the A, C, and V waveforms. That's your PA occlusion pressure, which is also an indicator of your left atrial pressures. Okay? And then you have your ventricular pressures, which is this. It looks like this. It's got the atrial kick, and it goes up, goes back down. But the pressures here reach 120, whichever your systolic pressure should be. Okay? Notice again that there's no dicrotic notch. Okay? If you had the arterial waveform, if you had no valvular disease, you should see waveform should mimic like this. The dicrotic notch occurs right there. Okay? All right. Any questions about anything so far? Now, the function of the atrial ventricular valves is the atriums. The pressure waveforms follow the A, C, and V waves. Okay, so both the CVP and the PA occlusion pressure. CVP is really measuring right atrial pressures. PA occlusion pressures is measuring left atrial pressures. Okay, and both those waveforms generate an A, C, and V. I expect you to know that for your test. Okay. The atrioventricular valves, which is the mitral and tricuspid valve, allow for more passive blood transfer. That's why there's so much enlarger and surface area. Okay, because the right ventricle is a little bit bigger in the sense of, in comparison, in the sense of its anatomy. If you look at the right ventricle, it looks more pyramidal shaped versus the left ventricle looks almost cylinder and circular in shape. Okay, they have completely different workloads, but how much ejection of stroke volume they have is actually very similar. The aortic valve closure point is where the volume begins to refill passively into the, which is part of diastole. So the point of diastole is when the aortic valves close and the pulmonic valves close. Okay. During that initial portion, which is isovolumetric relaxation, there's the mitral and tricuspid valves are also closed. And that usually indicates where the highest volume inside the atriums are. Very rapidly, though, after that, the mitral valves and the tricuspid valves open, which is the atrial ventricular valves open. Okay? This allows for passive and efficient transfer of volume by about 80% of the volume. So 80% of the volume that's arriving into both ventricles is basically passive. The atrial kick, which accounts for about 20% under normal conditions, is what drives the last bit of volume into the ventricles. And at that point, that's your maximal volume that you're going to have in the left and right ventricle, which we call the preload point. Okay? And that usually arrives right here. Okay, so right before the C wave, that's really what we're talking about when we're talking about preload pressures. Okay? Systole, of course, takes place when the atrioventricular valves are closed. They have to be closed through the whole cardiac systolic cycle, otherwise you're going to get regurgitation, which you're going to get a reduction in stroke volume. Okay, so really it's very important for the atrioventricular valves, which is the mitral and tricuspid valve, to stay closed during this whole time. It basically gives it a unidirectional blood flow, and it's basically its job is to remain closed despite intraventricular pressures that are being generated. So the mitral valve has to work much harder than the tricuspid valve. Remember the pressure differences. If you have somebody with a very severe hypertension, you guys don't realize this, but if you start thinking about this, this valve has to stay closed despite whatever the blood pressure that's being generated. And you guys have all seen this clinically, and you just don't really understand what's happening until somebody really describes it to you like I'm trying to right now. If you say you have an individual that has, let's say, an ejection of maybe 15 to 20%, they're doing fine. They still have a certain amount, they say they have 10 or 15% MR. They're walking around doing fine. But then they get emotionally a bad set of news, okay? And they get really upset. And as soon as they get upset, their blood pressure starts going up, okay? Because their vasosympathetic nervous system kicks in. Their blood pressure goes up to, let's say, 200, okay? What does that mean inside the left ventricle? The left ventricle has to generate 200 to reach that arterial pressure. It has to generate that. Otherwise, forward flow is going to stop. So it has to generate that pressure. And in that same time, the papillary muscle has to hold harder to hold down the mitral valve to become incompetent. Okay? Well, guess what? At 220 or 200 blood pressure, the mitral valve is not going to stay competent. Okay? The mitral valve is going to open up, and a certain amount, instead of 10% mitral regurg like this guy had, now he's going to have 40% mitral regurg. Okay? So 40% of the volume is going, so it should be going forward, now she's going backwards into the lungs. The pulmonic volume increases dramatically. The person gets increase in volume, and all of a sudden you see them breathing faster. Okay? And then very soon, if you don't take care of the blood pressure quickly, the person is in full-blown failure. And then you'll say, well, it's hypertensive-induced congestive heart failure. Yes, it is. But you really have to understand that the mechanism is that the mitral valve has become incompetent. Volume is regurgitated back into the pulmonary veins. Then it's gone into the pulmonary arteries. Capillaries leak in fluids. And if you wait too long, it leaks into the capillaries, into the interstitial space, and then it starts overflowing into the alveoli. And then you get frothy red stuff coming out, and that's pulmonary edema. Okay? That's how we want you to start thinking. Okay? We want you to sort of, what is going on? Why is it occurring? That's why hypertension is not safe. Hypertension is dangerous. It can hurt somebody. Okay? Especially if they have limited cardiac output. Okay? That's it on the valves, and that's all I expect you to really know for the test. Just know one other thing that I just want to make sure is that the function of the arterial valves is basically to cause a unidirectional flow of blood. It basically sets up the pumps to be in series from the right to left ventricle, okay? And it protects the ventricles from back pressure, from the aorta itself. So when the aortic valves close and pulmonic valves close, they protect the ventricle from that. Members should know the differences between resistances, between the pulmonic and systemic circulation. And remember that the aorta provides all the coronary and systemic circulation. Okay? So if you lose the aorta, game's over. Okay? And usually it's a pretty quick death. If you see somebody rupture the aorta, they're down in about 2 seconds. It doesn't take long.